half-lying position. We find the psoas medially to the sartorius and just under the inguinal ligament. Deep friction with the homolateral index finger and middle finger and fulcrum thumb. The fingers are set in flat. The pressure is increased gradually. The fingers remain in the depth. The patient sits. The rectus lies laterally to the sartorius. Normal version of the deep friction with flexed fingers of the homolateral hand and fulcrum thumb. We look for the end of range and stretch up to 1 minute. We look for the end of range and stretch up to 1 minute. Details: a hand on the upper part of the femur, no knee flexion, our own knee under the patient's thigh. We look for the end of range and stretch up to 1 minute. We check the relaxation of the hamstrings. The couch is set in a low position. In order to get the leg horizontally, we need a cushion. There is a posterior stabilization by using the thigh and an anterior one by using the fingers. Large reserve of skin. A flat thumb contact reinforced by the other hand. We use our body weight in an anterior direction and release the pressure when coming back. The pressure is increased gradually. Prone lying with the knee in 90 degrees flexion. Normal version of the deep friction with all fingers and fulcrum thumb. The patient lies on the painless side, 90 degrees hip flexion. We stabilize the patient with our thigh. This is the normal version of the deep friction with the heterolateral flexed fingers, reinforced and fulcrum thumb. One assistant builds in traction at the head or the arms. We immobilize the patient with a girdle. The The middle of our fifth metacarpal bone is set in comfortably on the lower vertebra. The other hand reinforces. We take up the slack by using our body weight. The patient relaxes. Traction. 1-2 seconds later, we manipulate. The manipulation is a swift head and trunk movement with straight arms. For example, left rotation. Contact on two transverse processes. Lower left and upper right for left rotation. The sequence is as follows. For the left rotation, we stand at the patient's left side. The left hand is set in pisiforme on the left transverse process of the lower vertebra, with the fingers pointing in a downward direction. The right hand, carpometacarpal joint of the thumb, is set in on the right transverse process of the upper vertebra, the fingers pointing in an upward direction. In order to move the paravertebral muscles away, we put the hands transversely first, get some reserve of skin superficially, and then turn 90 degrees in the depth. For a right rotation, the right arm is behind the back. The assistant builds in traction and 10 degrees of right rotation. Left hand at the chin. Left elbow around the patient's shoulder. The other hand flat on the right half of the thorax, T6, T8, fingers crossed. We take up the slack with the hands, followed by traction and manipulation. Manipulation is a trunk side flexion to the right. This is the normal version of the deep friction with middle finger and fulcrum thumb. Arm in light abduction. Pinching grip between thumb and finger. A straight movement, a large reserve of skin. Hands behind the back. As much medial rotation as possible. We may use a cushion under the shoulder. We palpate along the medial edge of the scapula in order to find a lesion. The deep friction is the normal version with flexed and reinforced thumb. The patient lies on one side of the couch. The therapist stands at the same side. The patient's head is well stabilized by using our abdomen and one hand on his forehead. Flat thumb on the lower row of teeth. The fingers are flexed under the mandibular. We build in traction and carry out a gliding movement of the chin to the left or the right. To find the joint, open and close the mouth while palpating. The deep friction is the normal version with flat thumb.